Hi everyone, welcome to Discussions with Dr. G. I am your hostess, Dr. G. So let's set the table for today and talk about neurosensory disorders and specifically what it means for you when you're a brand new nurse staring down a patient assignment with a little bit of terror in your soul. Welcome to the club, right? Now, when we talk neurosensory, it's going to be the big three: vision, hearing, and balance. Yeah, there's more. There's pain, temperature, and touch too. But for daily function, ADLs, mobility, just getting through a Tuesday, those first three are going to be the heavy hitters. If any of these afferent pathways go wonky, think visual or hearing disruptions or problems with balance, suddenly your patient isn't just struggling to read their menu, they're at risk for falls, feeling socially isolated, and you've got yourself a complicated case. I'll never forget my first community health visit, literally day one out of orientation. I get sent to check on a sweet older woman, and she'd fallen right before I arrived. Turns out she had undiagnosed benign paroxysmal positional vertigo, BPPV. First thing through my mind, well, there goes my blood pressure. But really, it hammered home how these deficits can be sneaky. Without a thorough assessment, you miss stuff that can absolutely upend someone's life. So, as nurses, here's what you got to keep top of mind. Safety. Always, always, always. Fall risk, both in the hospital and at home, is huge. Accurate assessment, because symptoms aren't always going to look textbook. Medication vigilance, not just did they take it, but should they take it? And don't even get me started on geriatric pharmacology. Plus, you're going to want to loop in other folks: pharmacy, physical therapy, audiology. Don't try to Lone Ranger the whole thing. Teamwork will save you, trust me. Let's dive into vertigo. The playground nobody wants to visit. Meniere's disease and BPPV, right? Both are notorious for causing that spinning, I just got off the tilt-a-whirl sensation. In Meniere's, there's a buildup of endolymph in the inner ear and it trashes the labyrinth. The result? Episodes of vertigo lasting minutes to hours, roaring tinnitus, progressive hearing loss, sometimes a feeling like you stuffed your ear with cotton balls for absolutely no reason. Super fun. BPPV, on the other hand, those tiny calcium crystals, the autoconia, decide to take a vacation and end up where they shouldn't be, triggering vertigo with sudden head movement. Usually it's intense but short-lived, like under a minute. Some poor souls win the jackpot and get both disorders at once. Symptom-wise, it's all about vertigo, nausea, vomiting, and this miserable sense of imbalance. You can see why fall injuries and social withdrawal are major risks. And don't underestimate the mental toll. Anxiety, depression, job issues, all wrapped up with a pretty little bow. So what do we do now? Non-pharmacological is going to be your baseline. Diet tweaks, managing caffeine, salt, some vestibular rehab, environmental safety checks. For medications, antihistamine like meclizine are first line for symptom relief. Definitely not a cure. Meclizine works by blocking H1 histamine receptors with a bonus of anticholinergic effects, so it calms the vestibular system and the vomiting center in the brain. But, and here's where it gets real fun, side effects in older adults especially can be gnarly. Dry mouth, blurred vision, constipation, confusion, even arrhythmias or delirium. Quick story. I put one of my older patients on meclizine after her doc suggested it. Within 48 hours, she called me confused and acting more off than usual with a Sahara dry mouth. Fall precautions became a full-time job. That's why med reconciliation, close monitoring, and teaching activity restrictions are crucial. Be a detective. If your patient suddenly can't find their words or gets wobbly, it might be the meds and not the disorder. For Meniere's, sometimes they'll throw in diuretics, corticosteroids, antibiotics if an infection is suspected, always tailored to the patient. And please don't just toss more meds in without checking drug interactions, sensitivities, and of course, the patient's ability to handle and manage it all. Nurses equal safety net. So let's switch gears. Let's talk eyes, specifically age-related macular degeneration, or AMD. The prime suspect when someone says, I can see, but my center's all blurry. There's dry AMD, a slow progression of vision loss with those precious central vision cells. And wet AMD, which is all about those pesky new blood vessels leaking and wrecking the macula, causing rapid central vision decline. The fovea, which is our high definition camera, gets wrecked and boom, there goes depth perception, mobility, and driving. AMD doesn't just take vision, it chips away at independence, lost confidence, higher fall risk, trouble with nutrition. There's a lot of anxiety and even depression wrapped up in there. And please don't ignore the caregivers. Family roles are going to change, and the need for emotional support is huge. Diagnostically, you'll see vision testing, dilated eye exams, OCT scanning, plus the Amsler grid as a home monitoring staple. If someone calls you and says the line started bending, Houston, we have a problem. For dry AMD, all we have is slowing progression. AREDS 2, nutritional supplements such as antioxidant vitamins called Age-Related Eye Disease Study 2. These supplements help, but they don't restore sight. For wet AMD, the rest of the alphabet soup, we have intravitreal anti-VEGF injections, like ranibizumab, bevacizumab, and aflibercept. These are administered by ophthalmology, not us, since they're intravitreal. These can stabilize and even slightly improve vision if the stars align, but it's all about strict adherence and recognizing trouble quickly. So your nursing focus for anti-VEGF injections is going to be to teach patients about the red flags: severe pain, increased floaters, sudden vision loss, signs of infection. Remind them don't rub, avoid eye strain right after injection, sunglasses for photophobia, and hit every single follow-up. These shots are sterile procedures administered on a schedule that feels never-ending. Keep in mind to educate the patient that mild discomfort is fine, but they need to watch for the bad stuff like endophthalmitis or retinal detachment, as these are sight-threatening emergencies. Let's finish up with technique because, well, contaminated drops or otic solutions are a rookie mistake you only make once. For otic meds, you're going to position the ear up, pull the pin up and back. Don't touch the dropper to the ear or anything else. Do the tragal massage and keep the patient lying there for 5 to 10 minutes. For eye drops, you're going to pull down the lower lid. You're going to not touch the dropper to the eye or anything else. You're going to place the drop in the conjunctival sac, press the lacrimal duct for a good 30 to 60 seconds to cut systemic absorption. Always educate the patient on infection prevention and document everything. All right, that's my RN safety checklist. If there's one thing I want to leave you with today, it's that neurosensory meds are symptom managers, not cures. Safety comes first. Prevent falls, protect vision, keep an eye, yes, pun intended, on infections. We don't just toss meds at people, we educate, advocate, and make a real difference. All right, that's enough of my soapbox for now. Catch you on our next episode where I promise more weird stories, clinical tips. Stay safe out there.